Good afternoon again. So for this endoscopic sessions, I'm going to talk both about the transforaminal and also intralaminar. We tried our best, actually Suleiman tried. He asked me about 4 months ago that we should show this a live surgery. We both tried, but because of the local provider and the JoyMax, we couldn't manage to do that. So I hope next year Suleiman will bring him and we'll show you the live surgery. So let's go into the historical background. The first surgery for disc was performed in 1934. It was a Mixter and Barr who did the first laminectomy and found out that's how you relieve the sciatic pain. With time, we realized that it's not only the laminectomy, you have to take the disc out of it as well. So the surgeons start doing laminectomies and discectomies. In 1968, it was the first time with the advent of microscope, it has become, the neurosurgeon opted that and it became a gold standard. So the endoscope was first time devised in 1993. And then with the further advancement in the anatomy and the Camben device, the Camben triangle, the endoscope is becoming now more and more popular. If you go to China, there's a lot of the Chinese surgeons who are taking all the discs almost endoscopically. So gradually with time, it will become a norm and a gold standard. So it has got added advantage, especially the transforaminal on any open surgery, because it's a very short hospital stay, minimal blood loss. So we know there's one of important muscles, which we call the multifidus muscles, which maintain our segmental stability. It is attached to the spinous process and go to the transverse process. Any surgery will give a cut. We cut that muscles from the midline if we move any structure laterally. So that's why the concept of the minimal invasive spine surgery came, and that's how the endoscopic spine surgery is. Because you can cut that muscle, patient will be fine post-operatively, but he will develop some sort of more post-operative pain, and the rehabilitation will be longer. He will ultimately recover, but rehabilitation, in order to make the rehabilitation shorter, we don't want to go in the midline and disturb the midline structures because they maintain the segmental stability. Another thing, which is this surgery has the advantage of all the surgeries which we have discussed since morning, that you don't violate the spinal canal. So you go straight on the target through the foramen. And once you enter through the foramen, you are not violating spinal canal. And after 3 and 4 hours after surgery, you feel safe, you can send this patient home because there's no chance, or there's a very, very rare chance of developing the blood clot. Wherever we do any surgery, when we violate the spinal canal, how good surgeon we are, we can't control the post-operative clot if it happened afterward. With this surgery, it's very, very unlikely you will get because you are not violated, you are not in the spinal canal. And obviously, it's good for big and obese patient because with the endoscope, its size is about 6 millimeters. So the maximum incision you give is a 7 millimeter. It doesn't matter how big or small the patient is, what's the size of patient. That's another added advantage that cosmetically it is very good. And second, if you have doing a revisional microdiscectomy, you go through the scar tissue and there's a chance of causing the CSF leak and nerve injury. Although once you are experienced, you don't do that, but that increase the chances of that. But doing the endoscopic, going through this route, you are going through a normal vision field, and you are unlikely going to cause the CSF leak or damage the nerve. This is a prospective randomized control trial where they put 50 patients in a group where they did the standard, and the 50 patients, they did the muscle-sparing microdiscectomies. And they measure the 3 criteria. You measure the CPK, the muscle damage proteins, and they also measure the visual analog score for a back as well as the leg pain. And if we see here, it's almost same that 1 day before surgery, day after surgery, 3 days and 5th days. But when we come here, we clearly see that when it moves to the day 3, and in conventional and muscle sparing, there's a difference, and the p-value is significant. So the CPK went up with a conventional microdiscectomy as compared to the muscle sparing. So there's a less damage to the muscle. If we come down now to the lower tables, and we see here, there's a difference in the visual analog score on day 3 and 5, and p-value is significant. So this means if you cause a less damage to the muscle, there will be less rise in the CPK, and there will be less post-operative back pain. While for the leg pain, they were similar. And there's another study where they compare the 15 patients in an endoscopic group versus microscopic group. And again, the conclusion is same, that endoscopic procedure is less invasive because there's a less change in the CPK and muscle damage, and the patient recovery and rehabilitation is quicker. So like any other approach, we discuss all the open procedure and deformity surgery. The anatomy is paramount and is very important. So for here, the anatomy is also very important. We must understand the anatomy of the foramen before we do this procedure. So I will describe briefly the content of the foramen, its anatomy, the lumbar nerves, triangle of safe zones. So if we see here, the foramen are in the sagittal view. If you see, the foramen are taller when we are higher. And as we come down, the foramen becomes smaller and shorter. And the boundary of the foramen, it is bounded by the superior pedicle above, inferior pedicle below, and its interior wall is formed by the disc and adjacent vertebral body, and posteriorly, it is the facet joint and pars. And if we see now the size of these, it's the L5S1 is where the, as Dr. Zelmi was saying, because L5-1 is the most difficult level to do. Because the foramina has changed, it's in reverse. Because the foramina is less taller and more wider. So that's where you can cause the problem. So when you start in the beginning, not try to start with L5S1. But obviously, once you become experienced, I can reassure you there's no harm in doing the L5S1. You can do as good L5S1 as L4-5. But in the beginning, not try to do the L5S1. Another important structure or content is the nerve root. If we see here, so the nerves occupies, the exiting nerves occupy the upper 50% of the foramen. So this means the lower 50 is empty, and that's the safe place or a safe zone to enter. So whenever you place any instrument or a needle, go through the lower half. If we now go to the course of nerve, we see the nerves are longer as we are higher, and it becomes shorter as we come down. So if we see that the ganglion is usually extraforaminal at a higher level, but at L5S1 in 80% of the cases is intracanalicular. So when you go to the L5S1, you might have removed the disc very nicely, but if you manipulate the ganglion, patient will wake up with dysesthetic pain. So when you are doing L5S1, so you should be careful about that as well. And this is the Pervez Cameron who first time described this triangle. This is the triangle of safe zone. That's the exiting nerve root, traversing nerve root, and the inferior boundary is formed by the superior end plate of the vertebra below. So this triangle, so all instruments should go through this triangle. If we stay in this triangle, we'll be safe. And while being a surgeon, our job is to manipulate this triangle, to increase the diameter of this triangle, so we should enter this triangle safely without damaging the exiting or traversing nerve root. I mean, this is one of the cadaveric studies which shows that when you are doing transforaminal, we are worried we might damage the theca and cause a CSF leak. We are usually about 7 to 10 millimeters away from the theca. So we are not going to damage the theca. The only thing which is at risk is the exiting nerve root. And that's why I do this operation always awake. I never put the patient to a general anesthesia or any other anesthesia. I do the patient awake. That's a direct neuro monitoring. So that's how we start using, that's the dilators or reamers we use. And once we remove this facet or we ream this facet few millimeters, We just need a few millimeter. And when we ream this facet few millimeter, we are violating the Cambrian triangle. We are increasing the diameter of the Cambrian triangle. And when Cambrian triangle become bigger, it's safer. That's why we never try to come down and hit the nerve directly. We always, whenever we place the first needle, we come straight on the bone. And then we can walk through the bone. We never try to get straight into the foramen. And we use a traffic light system. We start with the green and then we go to the yellow and then to the red. So the reason is because when you start with a small diameter, if you are not harming the patient, then you move to the next level and then you move to the next level. So we can't go straight with the red. And in the beginning, when you are doing, start at L3, 4, L4, 5 days. L5S1, if the iliac crest is low, that sometimes hampers you, but when you do a lot of cases, you don't need to that. Relatively young patient. And don't try to do when there's a high grade disc is migrated highly upward or downward, just where the disc is. Lot of neurosurgeons, they go for the courses, they come and do the cases, and they don't opt this surgery because it's technically, as Dr. Zelmi was saying, it's a technically demanding surgeries. And you need to do a good 80 to 100%. It's a steep learning curve. You need to do a good 80 to 100 cases before you become proficient and start giving the good results. Otherwise, you get a lot of recurrences, patients are in pain, and you get demotivated. So there are different kits available in the market. I use the Joymax. That's the only company who's only work on the spine endoscopes. And they have a lot of innovation and research and bringing new equipment and instrument. So this are the endoscope which goes transforaminally, 30 degrees. This is, we call it a bipolar. The advantage of this is you can work very close to the nerve without harming the nerve. It doesn't heat up. It's work at a low temperature, no carbonizing effect, and it's very nice to clean the tissue, and you can work close to the nerve without harming the nerve. And I think this is paramount with this sort of procedures. Another is, as I said, we can use the drill or shrill. When you are in and you are not confident, you have done enough foraminotomy and you want to extend. So now the drills are available. You can increase, you can remove more facets to improve the diameter of the Cambrian triangle, and then you can work very nicely with the help of these. So patient can be done lateral or a prone position. Being a traditionally neurosurgeon, we are more geared to do everything in prone. That's how we are learned. But I do in a lateral position. I think the lateral position had a certain added advantage. Because if your lateral position, when you break the table, you open up the foramen. And once you open up the foramen, then it's easy to get into that. Second, when you do a lateral, the neural structure due to gravity will fall away from you. So your instruments are coming on the top. So neural structures are away from you. But if you are doing prone, then the neural structures are more toward you. And when you are using the instrument, you are coming close to the neural structures. Another advantage with that is, if you put the patient prone for 45 minutes, 1 hour, he can't lie prone without general anesthesia. So you need to be anesthetized. In the lateral position, you can do under local anesthetic. So that's another reason I do in a lateral position, because for direct neuromonitoring. So that's how I mark. I wish we should have shown you that surgery, but couldn't manage to do this time. So this is the midline I marked, 10, 12, 14. That marking depends upon the size and the level disc where we are trying to remove. The more higher you are, you need a less angulation. More lower you are, you need a more angulation. Second, it depends upon the location of the disc as well. So if you are having, say like L5S, it's an upside down diagram, I put it deliberately. If you are doing L5S1 laterally, posterolateral, you start with a very obtuse angle. If it's a far lateral disc like this, then you make a more acute angle to come to outside the foramen to take the disc out. So that's how we place the needle. The important thing is that on the lateral view, you should not entering into the disc space, because the microscope sees 10 times better than our naked eye, while endoscope see 40 times better than our naked eye. So if you enter into the disc, then you lost within the nuclear pulposus. And normally it's an excluded fragment which is causing or compressing the nerve. So you are fishing the extruded fragment, not the entering into the disc and removing it, unless it's a contained disc. And on the, if you see the AP view, you should not cross the medial pedicular line. So then you use the next set of instruments, which I said, the traffic light systems. Then you use the dilators. And ultimately, some people do the discography. When I started, I was doing that, but I stopped that. There's no need for discography. But if you do a discography and inject the chymopropane, so it will glue, it will become the structure will glow blue, which is degenerated or extruded fragment, while the normal disc will not become blue. So that's how you find where the extruded fragment is to remove that. But I don't use anymore now. So then you place the endoscope and you start removing the disc. I will play a little video. So now you see through the transforaminal, when I started initially, there was not many instruments. So now they got endo, reamer and rongers, like upcut. So you can nicely unroof the nerve. You see here, I was unroofing the nerve. Now I'm working close to the nerve. This is the nerve, that's a disc. And now I'm going under the disc to, under the nerve to fish out the disc fragment. And this is the disc fragment which is coming out. You see the nerve is nicely pulsating and is decompressed. Now you can do a sort of foraminectomies as well by removing the excessive bone if you have to. I will go for a next video. So this is the disc which is coming out. This is ligamentum flavum. It will become more clear in a moment. So here is I'm removing the disc. So now we see here, that's the exiting nerve root. This is the exiting nerve root. And I will show in a moment, because exiting superficial, because you are going through the foramina. And this is the traversing nerve root. See how nicely it's decompressed now. That's the traversing nerve root. I will. So that's how we decompress. We see both exiting and traversing. This was a disc which was migrated inferiorly. If you have a superior disc, want to go back on that side, so you just work in the upward direction toward the exiting nerve root. So you can remove the upward migrated or a fall lateral disc to this. So rather than doing a fusion operation for removing the whole facet and taking it out and decompressing, I think this is a very minimal invasive approach. You can easily take the fall lateral disc out, or you can take the medial disc out. So I usually show this diagram. This is a patient that's his midline, and he has a surgery. When I did his surgery, now it was 15 years ago, an orthopedic surgeon did this curvilinear incision and removed the L3-4 disc. He came with a recurrence, and I went through the endoscope, and that's the incision now. This is another patient, that's the midline, and that's the incision. So it's cosmetically very, very acceptable. Thank you, and I will go for a next one. So this is for intralaminar approach. Initially, I was a bit critical of intralaminar approach. The reason is because with the tubes, or with even microdiscectomy, you are violating the spinal canal, you are entering into the spinal canal. In my opinion, I like doing the transforaminal. I think with the transforaminal, you can, other than cardiac vena, which we presented patient as a urinary and bladder valve loss in the beginning, I will not do cardiac vena. Otherwise, I can do all the disc can be done through the transforaminal approach. But some people do more this. It has got its own place and indications. I will go for that. So if patient has a high iliac crest and if you can't get to the L5S1 foramen, if you have a very upward or downward migrated fragment, especially at L5S1, if you have a lateral recess or especially central canal stenosis, so you either use endoscopic approach, interlaminar, or you do tubular or micro interlaminar approach, whatever you like. So patient is lying prone with this, so it's always generally done under general anesthesia, but you can do under spinal anesthesia as well. But I will pressure, if I'm putting the patient prone, we give a general anesthesia. So there's a different types of endoscopes which is available. So the scope which we use, so these are called Elysis, and there's a different types. It's Elysis Delta, Elysis Pro, and Elysis Short. There's 3 different types of scope which we use, and they have got different indications. Whether you are removing the disc, whether you are doing the central canal stenosis, whether you are just removing the thick ligamentum flavum, or you're doing the lateral recess stenosis. So there's a different scope for a different indications. So this is the Elysis Short. This is Elysis Pro, and this is Elysis Delta. And what are the different distance? If we see here, this is the Elysis Delta. So if you have thick flavum, ligamentum flavum, you use the Elysis Delta. If you want to be a little bit deep down to remove the disc, you use the Elysis Pro. And if you are going laterally and contralateral side, then you use the Elysis Short. So larger the instrument we use, the scope diameter is larger, the inward diameter is show a small view. So if you have a small scope, you can manipulate, you have more freedom to maneuver it. And I think this is the added advantage over the tubes, because if you have using the tubes, you have to fix the tubes with the table. You have to mount a table, and then your hands are only free. And then you can see only under microscope through the tubes. With this endoscope, the advantage is you hold in the hand and you move. So wherever you want to go, you can move it. And as you said, the suction pumps are available. It's constantly sectioning and providing the water. So you can do much more, like we do when we think about the transcranial concept, when we do the transphenidal. If we do the microscope, we go straight into to remove the pituitary, but we can't go lateral. With the endoscopic pituitaries, you can go into the corner. Same rules applies here. With the tubes, you are a straight tunnel visions. With the endoscope, you can have a more freedom and you can maneuver laterally and probably can do more better decompression. So it has got a big working channel, especially these posterior scopes as compared to the lateral scopes. And the principle is same as we applied for the tubular techniques. You can use for a disc. You can take the disc with this technique, like this, especially disc at L5S1. If you have an upward migration or downward sequestrated fragment, it's easy to use this approach rather than transforaminal. But I still say with transforaminal, you can do that as well. Sorry, I'm good. Trying last bit. So this is the sequestrated fragment. Again, can be done with either approach. So it depends. With this, I said this is the advantage, great advantage. So if you want to go to the shoulder, you can move the scope upward. It's free in your hand. With if you are using the tube, every time if you want to move the tube, you have to unlock and then do it again. With this, you can move wherever you like. And if it's axilla, you use a slightly different approach. Same in the lateral view, you higher, you can come lower, wherever you want to. It's a lot of freedom with this sort of technique. So it's to remove the disc. And if there is a lateral recess stenosis, you can use this to take the lateral recess, decompress the lateral recess. If you see here, if you do the facet and ligamentum flavum, you use the scope here, come around that and remove with the help of these Delta Pro. And this is the unilateral. If there's a thick ligamentum flavum, similarly, you can decompress by using this. This is the typical example. If there's a thick ligamentum flavum, you use the Delta Pro to remove that, or Delta Elysis to remove that. This is another central stenosis, and you start with this initially with the dilators, and then ultimately you put the scope on, and then you start drilling. So now, if you are using the microscope, obviously you then with the tubes you have to fix it. Then you can use the endoscope only under microscope. If you are using without microscope, it's very dangerous. With the endoscope, the advantage is you are holding with one hand, and then you can use the endoscope, and you can go medially, laterally, opposite side. You can go on either way. So that's the great advantage of the endoscopic discectomy. So now they brought initially, because they were not having all these instruments and it was very difficult. That's why the neurosurgeon board moved to tube. But with these drills, with these endorongers, you can do anything. So this is another central stenosis, and this is pre, and that's the post-operative decompression. This is a central stenosis here, and you see how big is the difference. This was a pre, and that's after drilling it out and removing the thick ligamentum flavum. You can see the window is increased. Then it's for lateral recesses. You can do ipsilateral side, or you can go on the contralateral side, more like principles of tubes. And using these endorongers, you can remove thick ligamentum flavum, you can remove the bones, you can remove the flavum. Here you see the narroot, and that's the ipsilateral decompression. That was pre, and that's the post. You can go on the contralateral side on C. You can check under X-rays. You are working from this, and you are working completely on the opposite side to remove the opposite. This is the contralateral narroot, and that's the post-operative. That's the, you just need a few stitches. So that has got its own place. So you can, if you want to become an endoscopic surgeon, you should have a combination of both transforaminal and interlaminar, and then you can cover most of the pathologies. So I think there are a lot of endoscopic courses going on. So we are trying to organize one in London in September. So it will be a pure 2-day course on a transforaminal and endoscopic, nothing else. So if any of you guys are interested, you are most welcome. Thank you.